Good afternoon, ladies and gentlemen. Welcome to the APSC Cloud Forum of Cardiovascular Disease. Shall we start? Shall we start?
Yes.
Okay, thank you. Good afternoon, ladies and gentlemen. Welcome to the APSC Cloud Forum of Cardiovascular Diseases series. The forum today focuses on the adult congenital heart disease 2022 update. With medical advances, the adult congenital heart disease, ACHD patient will grow not only in population size, but also in the medical complexity. The estimates for the prevalence of ACHD were within the range of 2 to 6 per thousand adults in countries with established CHD programs. This webinar forum, entitled Adult Congenital Heart Disease 2022 Update, is to provide an overview on the innovative strategic care for the ACHD patient. After the webinar forum, the participants shall be familiar with the recent advances in the complex medical issues in ACHD, including arrhythmia, heart failure, pregnancy and labor, transcatheter intervention, and the transitional care. And we have 5 speakers to cover the whole scope. I'm Mei-Wan Wu from National Taiwan University Children's Hospital in Taipei. I'm honored to co-chair with Dr. Teiji Akagi. Dr. Akagi is currently the president of Japanese Society for Adult Congenital Heart Disease, and also the head of Cardiac Intensive Care Unit and the director of Adult Congenital Heart Disease Center in Okayama University Hospital. And the disclaimer from APSC is summarized as follows. The content of this webinar is copyrighted and should not be distributed without the permission. The view and opinion expressed are those of the faculty members. And live streaming content of this webinar will be made available via APSC Cloud, APSC Facebook, and YouTube page. Let's get started. The first talk is arrhythmia in ACHD. It's our honor to invite Dr. Jae-Yong Yoon from Korea to deliver the talk. Dr. Yoon is an outstanding pediatric electrophysiologist. Is currently the staff in Division of Cardiology, Sancheong General Hospital. Please join me to welcome Dr. Yoon.
Thank you for having me. I will start my presentation. Can you see my slide?
Yes, very well.
Yes. Yes. Thank you for your kind introduction. First of all, I would like to appreciate that I have the privilege to present this lecture. I'm Jae-Kyung Yoon from Sejong General Hospital in South Korea. I'm going to talk about arrhythmia in adult congenital heart disease. I will briefly explain the background of why we are here to talk about adult congenital heart disease. This is a nice graph from England that we can see the trends in the percentage of all CHD-related deaths over time. The number of infants who didn't survive have been decreasing as the cardiopulmonary bypass and surgical technique have improved. Recently, you can see the burdens of ACHD patients have increased, so we are faced with new problem of ACHD. In North America and Europe, there is more than 3 million ACHD patients, and they outnumbered kids almost 2 to 1. This population is rapidly expanding. That means progressive increase in ACHD admissions and increasing healthcare resource utilization for this patient. We have to focus on take care of this patient in this regard. So why are arrhythmia important in ACHD patient? From a rhythm perspective, there are many separated issues, but today I will cover two essential issues, including atrial arrhythmia and ventricular arrhythmia and sudden cardiac death. This is a Canadian study looking at their ACHD population. Overall, the 20-year risk of atrial arrhythmia was 7% in a 20-year-old patient. However, the risk increased to 38% in a 55-year-old patient. And looking at the cumulative incidence of atrial arrhythmia, almost half of the patients at the mid-60s have identified atrial arrhythmias. This incidence of atrial arrhythmia is different and it's depending on the congenital disease anomaly. The more complex anomaly and more atrial scar burden, for example, in the patient undergoing atrial switch operation or Fontan operation, ultimately end up with significant atrial arrhythmia combined. ACHD patients with atrial arrhythmia present a significantly increased risk of adverse events and mortality. And also, these patients are prone to more heart failure and probably a stroke. For this reason, we should be aware of atrial arrhythmia in ACHD patients and more aggressively treat it. So why are the patients with ACHD so prone to atrial arrhythmia? This picture is the way we explain how atrial arrhythmia developed from an EP perspective. Among these, CHD patients have more arrhythmia substrate than non-congenital disease patients. These substrates include congenital heart defect itself, surgical scar, hemodynamic loading, which result in myocardial damage and atrial enlargement, and also hypoxia. As you know, reentry is the most important mechanism of arrhythmia in ACHD. Typical atrial flutter rotates around the tricuspid annulus using the crista terminalis as the boundary. Cavo-tricuspid isthmus is a slow conduction zone and the target of ablation. CHD patients have got many other important substrates, as I told you. We can notice a flutter circuit around the patch and also find out the circuit formed around surgical suture line. ACHD patients with atrial arrhythmia are highly symptomatic and often poorly tolerated. And the thromboembolic risk in complex congenital disease patient is higher than in other patients. So for this patient, we should manage it arrhythmias promptly. Atrial arrhythmia in CHD is not so fast. So sometimes they do not have a palpitation symptom. In this ECG, in some lead, it may be so easier to see flutter rhythm, but in some of them, it's not so easy. Sometimes it's hard to recognize because the intra-atrial reentrant tachycardia could masquerade as sinus rhythm. But so you can see the baseline flutter rhythm if you check the Holter or use intravenous adenosine. So how do you manage this atrial arrhythmia in ACHD patient? As first, we have to identify and treat precipitation factors. In adult congenital disease, it's difficult to rate control, and many patients have a slow atrial arrhythmia. So we are almost moving to a rhythm control strategy. First, we can consider pharmacologic therapy. Because of lack of data, pharmacologic therapy is extrapolated from guiding principles established in non-congenital disease. Especially in CHD, the arrhythmia mechanism is usually reentry. So class 3 antiarrhythmic drug is a drug of choice, like amiodarone and sotalol. And in case of simple congenital disease like ASD and normal ventricular function, we can use class 1 antiarrhythmic drugs. When we prescribe the antiarrhythmic drug for ACHD patient, Considerations include the degree of systemic ventricular dysfunction and sinus node disease and impaired AV nodal conduction disease. And it can show a higher recurrence of arrhythmia. And sometimes in long-term use, the patient may experience an adverse effect. Sometimes we have no choice of drug. Because medical therapy has traditionally limited success, catheter ablation is emerging as a promising alternative option for this patient. 36-year-old patient with ASD, MPS, and status post-ASD closure at 8 years old was presented for severe TR and PR. She underwent pulmonary valvuloplasty and tricuspid valvuloplasty last year in our hospital. In the early post-operative period, arrhythmia was developed. This ECG shows intra-atrial reentrant tachycardia with heart rate 103. It's relatively slow tachycardia. During follow-up, her tachycardia frequently recurred and was highly symptomatic. And after the termination of tachycardia, a significant pause of up to 3 seconds was observed. So we decided that she should be brought to the EP lab for catheter ablation. Using 3D mapping system, we identify her tachycardia was CTI-dependent IART. In voltage map, you can see her diseased atrium. This is what we call an isthmus. This wave of electric activation circulating around tricuspid valve and conducted through the isthmus and back it up. So we ablated CTI successfully and tachycardia was terminated. After termination, we got the 6-second sinus pause. In many cases, we can get another circuit. This 54-year-old patient who underwent repair for sinus venous type ASD and PAPVR was presented with tachycardia and was brought to EP lab. She has already got CTI ablation. This red area means the low voltage is a scar, look like an atrial incision, surgical incision scar. You got the IART traveling around the incision scar. So we ablated for RA-free wall scar to IVC line. Tachycardia was successfully terminated. In general, the Pontan operation has saved many lives, but it's complicated by arrhythmia and other Pontan failures. Pontan patients have a large atrium and multiple scars, so this patient may have multiple different forms of potential reentrant circuit. In Pontan patient with ECC conduit, for access to the pulmonary venous atrium, direct conduit puncture is required. Transcaval puncture or transpulmonary puncture can be used, but still it's very tough job. And we are always aware of where the intrinsic conduction system is because we should avoid iatrogenic AV block or sinus node dysfunction. Sometimes we may encounter multiple different tachycardia during EP study. It's not easy to distinguish what clinical tachycardia is. This all thing makes catheter ablation a challenge. So we should weigh the risk and benefit before we decide on catheter ablation. Looking at the outcome of catheter ablation, acute success rate up to 80%. However, it's not satisfying that the recurrence rate is up to 34% to 80% at more than 5 years of follow-up. More complex atrial anatomy like mustard or Pontan was associated with higher RFCA procedure failure rate and higher recurrent rate. So in adult congenital disease patients, atrial arrhythmia could develop relatively young and more AT and flutter at presentation, but it could progress to AP rapidly and persistently. So we should treat this arrhythmia more aggressively, especially when it's an organized form like IART or AT. And there is another topic, thrombosis. Actually, complex congenital disease itself is a higher thrombogenic state. Here is an ECC spontan patient who has a long history. He was presented atrial fibrillation. If hemodynamics deteriorate, DC cardioversion would be considered. However, we know that spontan circulation is prone to a thrombosis, so we cannot apply the adult guideline as it is. This busy chart showed ACHD guideline thromboprophylaxis in arrhythmia. In case of more than moderate CHD, TEE or 3 weeks anticoagulation before cardioversion was strongly recommended regardless of arrhythmia duration. And also for long-term thromboprophylaxis in more than moderate CHD, warfarin is usually recommended so far. Although we can try catheter ablation for AFib, but the role of AFib catheter ablation is still limited. More complexity anomaly is less acute success rate and higher recurrent rate. Also, we have to consider surgical option. A combined MAZE procedure is reasonably effective to prevent and treat atrial arrhythmia in patients with CHD. The recurrence rate is still not low, but it can be one of the options for reducing the arrhythmia burden. So we are gonna move into sudden cardiac death. It's a big issue for adult congenital disease. When looking at the cause of death in CHD patient, sudden cardiac death is one of the leading cause of death following heart failure. According to recent data, about a quarter of mortality in adult congenital disease is going to be sudden cardiac death. So that's the reason we have to follow up this patient carefully with risk stratification. Of them, arrhythmias account for approximately 80% of all sudden cardiac deaths in congenital disease population. Ventricular arrhythmia are most common events. Although the incidence of sudden cardiac death in the CHD population is relatively low, but specific subgroup of high risk include tetralogy of Fallot, systemic RV ventricle, left-sided afro obstruction lesion, and Eisenmenger syndrome. This table shows atrial arrhythmias have been noted to trigger malignant ventricular arrhythmia and sudden cardiac death in susceptible individuals with several repaired complex congenital disease. TOF is the most common CHD associated with ventricular arrhythmia. As you know, repaired TOF patients have 1 or 2 patches at the VSD and or RVOT, which provide important substrate for ventricular reentrant arrhythmia. There is a lot of published data on what will predict sudden cardiac death in TOF. But I'd like to emphasize for if patient has LV dysfunction, QRS duration more than 180 milliseconds, documented non-sustained VT, induced sustained VT at EP study, you should worry about sudden cardiac death in repaired TOF patient who have this finding. So in this high-risk patient, we should consider ICD insertion for primary prevention. In this regard, PACE and ESC guideline make ICD for primary prevention recommendations similar. Catheter ablation has emerged as a useful tool to reduce the episode of VT or ICD shock. However, it should not be considered a substitute for an ICD in ACHD. But the subgroup of patients with successful ablation of VT isthmuses demonstrated bidirectional conduction block across them and preserved ventricular function seems to be at low risk of VT recurrence and sudden cardiac death. As technology advanced, the acute success rate is increased and the recurrence rate is also decreased in some selected cases. It's very encouraging. Another specific group of high risk of sudden cardiac death is patients with systemic RV. The morphologic RV is subaortic and prone to failure over time. Unfortunately, identifying high-risk patients in this group has been less successful than with TOF. Primary prevention with ICD may be reasonable in adult with single ventricle or systemic RV-EF less than 35%, particularly in the presence of additional risk factors. In general, ICD implantation is indicated patient with CHD with not tolerated VT or VPIP associated cardiac arrest survivor after exclusion of reversible cause. This is a secondary prevention. Currently, we have a 3 options for ICD. Subcutaneous ICD has been introduced recently, so it may overcome several limitations and be an attractive option, particularly for patients with whom intravenous access is not feasible. This is my take-home message. The burden of arrhythmia is increasing in ACHD. Atrial arrhythmia is more common in ACHD and are characterized a gradual transition from IART to APIP over the lifetime. Atrial arrhythmia is associated with mortality and morbidity in ACHD, so proper management is essential. Ventricular tachyarrhythmia and sudden cardiac death occur more frequently among specific ACHD. For prevention of sudden cardiac death, management of VT and risk stratification for sudden cardiac death is critical. Thank you for your attention.
Thank you very much, Dr. Young, for your wonderful talk, which is very inspiring. And I think arrhythmia is also a quite unique clinical manifestation of right heart failure in ACHD, and the management is completely different. Yeah. And thank you. And let's move on to the next talk, which is a topic focused on the heart failure in ACHD. And the heart failure in ACHD is quite different from that in general population. And the majority is right heart failure, and sometimes it's single ventricle failure, and only really this classical left heart failure. And the talk will be delivered by Dr. Junwei Lu. Dr. Lu is currently the director of ACHD Center in National Taiwan University Hospital. And he actually started the ACHD care program in Taiwan in 2008 and contributed a lot to this field and help a lot of patients to overcome their problems. Please join me to welcome Dr. Lu.
Thank you, Professor Wu. And today I'm going to talk about heart failure in ACHD. Heart failure is the leading cause of.
我没办法在麦克上帮你处理。
Heart failure is the leading cause of mortality, and it also from the German National Registry we can see it showed a trend of increase over time. The admission in ACHD patient due to heart failure showed an increase in hospital events, length of stay, and incidence of arrhythmia, and then in hospital mortality, then those without CHD. Because it is an important issue, therefore, in the year 2016, both AHA and the ESC proposed scientific statements for heart failure measurement in ACHD. There are some distinct nature of heart failure in ACHD, including it usually have diverse causes and pathophysiologies. These factors can all contribute to formation development of the heart failure, such as volume or pressure overload, myocardial dysfunction, pulmonary hypertension, systemic hypertension, coronary artery disease, no matter congenital or acquired, cyanosis, and intractable arrhythmia or dyssynchrony. And some specific lesions can easily associate heart failure, including systemic RV such as CCTGA, or complete TGA post-atrial switch, single ventricle with or without Fontaine, repair tetra follow with severe TR, or those patients with pulmonary hypertension or absent anomaly. Approach IS is the collaboration of 24 centers in 15 countries around the world, working on the patient-reported outcome for HSD patients. We recently published the investigation about heart failure in HSD patients. We include around 4,000 patients around the world. And found the patients are enrolled in outpatient clinic. The incidence of heart failure is around 11%. We noticed that older age and more complex CSD, presence of arrhythmia, patient with ICD implantation, the patient with other comorbidities, or patient with mood disorders are easily prone to develop heart failure. And we also noticed that heart failure can significantly impact the patient-reported outcomes, including physical functioning, mental health, quality of life, satisfaction with life, sense of coherence, and it can also worsen the feeling of patient's anxiety, depression, and the illness perception. And we noticed that if the patient had a more complex CSD, the incidence of heart failure is increased. Why are the depression are associated with heart failure? The possible mediating mechanism to induce heart failure due to depression, including the physiological factors and the behavioral factors, such as enhanced inflammation, autonomic abnormality, platelet aggregation, or vascular endothelial dysfunction. And some behavior factors, such as poor adhesion to physical activity, healthy diet, or medical therapy can also worsen the heart failure. Then, of course, heart failure can cause the patient more depressed. So this is a bidirectional mediating mechanism. Heart failure in HSD have distinct nature because the patient usually have lifelong adaptation to their physiological derangement. Therefore, the typical feature of heart failure may not be present. So the diagnosis of heart failure in HSD is usually challenging. I noticed a clear definition can recently be published. They define the patient with symptom sign of heart failure requiring therapy, plus one of the following criteria, such as impaired ventricular function, elevated BNP, and poor cardiopulmonary exercise test. And for those patients with Fontaine circulation, they present with protein losing enteropathy, plastic bronchitis, with higher systemic venous pressure or a poor cardiac index. And this criteria is usually is easier for clinical practice and for research purpose. Here are the signs of symptoms of heart failure in HSD patient. These are the symptoms for the left heart failure and the sign of the left heart failure. And there are some signs and the symptoms for the subpulmonary ventricular failure. But in many patients with of HSD, they have both sides heart failure. The key point in treating heart failure in HSD patients is to identify and treat comorbidities such as DM, hypertension, hyperlipidemia, thyroid dysfunction, or anemia. The following is to recognizing the underlying anatomy, awareness of the possible related complication for this underlying anatomy, and to examine the lesion for possible intervention, including hemodynamic or arrhythmia. And sometimes we need invasive hemodynamic evaluation for develop the treatment method for these patients. Unlike acquired CHD, unacquired heart failure, treating heart failure in HHD most rely on structural intervention, then following the device therapy, and the medication for this patient are in the third position. Here are the example of the specific anatomy and the common problem we should be noticed, such as tetrafallo. We have to notice the presence of pulmonary regurgitation or RVOT obstruction. And we just talked about the high risk of VT in such patients. And we should follow up for the possibility of occurrence of such complication and try to avoid the sequel. Some patients also had interesting myocardial dysfunction, so we may consider medications for traditional treatment of heart failure. However, in patients with HSD, this medication usually lack of strong evidences. These are some example of possible study results for treating heart failure in HAD patients. The items in yellow mark are the positive findings, such as beta blockers in systemic right ventricle, or beta blockers in single ventricle, and the pulmonary vasodilators for Fontaine circulation. And arrhythmia can both act as a cause and the consequence of impaired hemodynamic. IRT, atrial fibrillation, sinus, or AV node dysfunction may trigger or exacerbate heart failure. On the other hand, the volume overload, increased feeding pressure, low cardiac output, and hypoxemia may precipitate arrhythmia. So the identify and the management of arrhythmia in heart failure patient is also very important. For the very severe disease of heart failure in HHT patient may meet all 4 criteria as follows, such as episodes of congestion, lower cardiac output, or malignant arrhythmia, patient with severe cardiac dysfunction, or exercise impairment, and the persistent symptom of heart failure. If the patient meets all these 4 criteria, the treatment of heart failure should be more aggressive, such as we should earlier consider advanced therapy, such as CRT, mechanical circulation support, or heart transplant. For CRT in HAD patients with heart failure was recommended in those with NYHA functional class 2 to 4 symptoms with impaired systemic ventricular ejection fraction and prolonged QRS duration. The presence of a systemic LV predicted a better CRT response than the systemic RV. Those patients with systemic LV convert to CRT from conventional RV pacing with the best response. But in patients with single ventricular morphology, we may consider the CRT using optimal site of pacing. This is a recommendation for Heart Rhythm Society for CRT implementation for heart failure in HHD patient. The most recommended with class 1 is the systemic LV with LV dysfunction and prolonged QRS duration. But it can also considered in systemic RV and a single ventricle patient with lesser strong supporting evidences. The indication for transplant in HSD stage D heart failure refractory to medical therapy and those without benefit significantly from surgical intervention or electrophysiology intervention. CHD associated sudden death of life-threatening arrhythmia refractory to all therapeutic mortality are also considered to be transplant listing. For those with pulmonary hypertension with stage 3 heart failure, if he are prone to develop fixed irreversible elevated vascular disease, they can also consider listing for heart transplant. What is the outcome of the heart transplant in HHT patient? According to ISHLT registry, because the surgical procedure for HHT is usually more complex and risky. So in CHD recipient, they have a significant lower 1 year and 5 year survival. However, it showed a survival paradox for the longer survival because the HHD patient recipient are always younger. So they have significant higher 10-year or 15-year survival. The ventricular assistance device can also consider as testination therapy or bridging therapy. However, the utilization of VAD remain low in CHD population. The VAD may consider in systemic RV or a single ventricle. The outcome of mechanical circulation approach in HD is usually poorer than those without CHD. And recently published paper from Mayo Clinic demonstrated an important issue. That is for those with advanced heart failure in HSD, comparing to transplant listing, the conventional cardiac intervention showed very high mortality. Therefore, for patients with advanced heart failure, we may consider transplantation listing earlier. And for those with advanced heart failure, in the implementation of advanced care planning is also very important in our field. This is my take-home message. Heart failure in HSD is the leading cause of mortality, and it showed a trend of increase over time. It has diverse causes, and it was usually region specific. It was associated with old age, complex defect, comorbidity, arrhythmia, mood disorder. Presence of heart failure can also impact the quality of life. Treating heart failure in HD rely on identify and treat comorbidity, recognize the anatomy, and the awareness of the possible related complication. We should examine the region of arrhythmia and the hemodynamic direction for correction. In patients with advanced heart failure, early consideration of advanced therapy such as transplantation should be performed. Thank you very much.
Thank you so much, Dr. Lu, for sharing with us so many important information, including your multi-center study on heart failure and a lot of quality of life issues. And I think it's really challenging. Thank you. And now I would like to turn my podium to my co-chair, Dr. Teji Akagi.
Okay, thank you very much. So we'd like to move to the next speaker. Next issue is pregnancy and delivery for the adult congenital heart disease. This is a very important area. And we like to say, request for this kind of topics, Dr. Chizuko Kamiya. She's a very important member for our society, especially for this field. So Dr. Kamiya, please start your lecture.
Thank you, Dr. Akagi. Thank you very much for having me here. I'm very honored to present here. So let's share my screen.
There you go.
Oh. Okay, I'm going to start. I have no COI. At first, let me introduce our hospital, National Cerebral and Cardiovascular Center, NCVC in Japan. Our center is the only national institute specified for cardiovascular disease in Japan that consists of a hospital and a research institute. The OBGY department at NCVC sees more than 100 pregnancies complicated with cardiovascular disease annually. About 1/3 of them are complicated with congenital heart disease, CHD, and this graph shows an increasing number of those year by year. Today, I'm going to present 3 topics: pregnancy and labor in women with CHD as general remarks, then move on to postpartum concerns and contraception. After conception, maternal physiologic conditions, including cardiovascular systems, change dynamically. As for increased heart rate, increased blood volume, hypercoagulability, weakened arterial wall, and so on. In normal pregnancy, enough cardiac reserve and compensatory mechanisms, such as decreasing afterload against the increased preload, lead to a normal course of pregnancy. However, in some women with CHD, these physiological changes can cause cardiovascular complications, heart failure, arrhythmias. OB complications such as hemorrhage and hypertensive disorders may aggravate maternal condition too. Therefore, the rate of complications in pregnant women with CHD is higher than that in the normal pregnancies. The famous cohort, the HARA study, which included more than 1,300 pregnant women with CHD, showed arrhythmias in 4.8%, heart failure in 1.6%, and preterm delivery 12.3%. Multivariate model indicated that history of arrhythmias, cardiac medication before pregnancy, New York Heart Class, left ventricular obstruction, atrioventricular valve regurgitation, mechanical valve, and cyanotic heart disease were risk factors of maternal cardiovascular complications. Depending on maternal physiological changes, there are times when complications are more likely to occur. This is a very important point for preventing complications or diagnosing them as early as possible. During pregnancy, maternal cardiac output increases, especially in the second trimester, and up to 1.5-fold the pregnancy amount around 30 weeks of gestation. In labor, cardiac output increases more and peaks immediately after delivery because of oat transfusion. After delivery, it takes about 3 months to return to pre-pregnancy condition. Can you see 2 peaks of cardiac output? One is located around 30 weeks, and another is located in the second stage of labor and immediately after delivery. This graph indicates the occurrence of heart failure in patients with structural heart disease during and after pregnancy, reported by Lewis. As you can see, the peak times of diagnosing perinatal heart failure is bimodal at around 30 weeks gestation and between intrapartum and soon after delivery. Around such times, we must be more cautious when seeing perinatal women with CHD. And these are good times for cardiac exams, including echocardiogram. Here I'm showing one typical case of perinatal heart failure. Her diagnosis was TGA, and she had moderate mitral regurgitation after an arterial switch operation. She was in New York Heart Class 2 and took diuretics before her twin pregnancy. She started to complain of dyspnea on light effort after 30 weeks of gestation. Her chest X-ray at 33 weeks showed cardiomegaly and congestion. Cesarean section was performed at 34 weeks due to fetal growth arrest. 6 hours after delivery, her oxygen saturation dropped down and her pulmonary congestion became worse. IV diuretics and oxygen mask supply was started, and she recovered soon after. Move to the next talk. The figure shows maternal sympathetic nerve activity in normal pregnancy, which is increasing as the gestational weeks progress. In antepartum, sympathetic nerve activity exceeds parasympathetic nerve activity. During the latter half of pregnancy, heart rate are increasing up to 1.2-fold the pre-pregnancy rate. In a Canadian cohort of pregnancies with cardiovascular disease, CARPREG-2, the occurrence of peripartum arrhythmias was shown as blue bars in the graph. Many of arrhythmic events occurred in antepartum. From our experience, bradyarrhythmia tend to occur in postpartum. Here is a case of repaired TOF and severe pulmonary regurgitation. Her pre-pregnancy RV-EDVI was 168. Her QRS duration was 167 milliseconds. At her 24th week of gestation, Holter electrocardiogram was performed. During the exam, she complained of strong palpitation, which she had never felt before. Her Holter showed non-sustained ventricular tachycardia. To determine the maternal pregnancy risk, the modified WHO classification is often used. This classification categorizes women with heart disease into 4 or 5 pregnancy risk classes as determined by their medical condition. The European Society of Cardiology guidelines shows the approximate percentages of maternal cardiovascular events in each classes. For example, women in class 4 that are not recommended to be pregnant have 40 to 100% of peripartum cardiac event risks. Women in class 3 and 4 need special preconception counseling by experts. When they become pregnant, expert hospitals are recommended to manage such high-risk pregnancies. Now, I'd like to talk about labor. Women with CHD have a rising rate of preterm deliveries. At our hospital, the rate was 13.8%. Remarkably, most of them were decided due to obstetrical reasons. Many doctors have asked me whether vaginal delivery or cesarean section is better for women with severe heart disease. In vaginal delivery, less amount of anesthetics is needed than C-section. C-section tend to cause more bleeding, need longer bed rest, and have higher incidence of thrombosis. So, vaginal delivery should be the first choice in women with most CHD, However, in the second stage of labor, mother needs training and pushing. Therefore, we choose C-section as the first choice in women with Marfan syndrome whose aorta is significantly dilated or with acute congestive heart failure. We monitored maternal hemodynamic parameters in normal pregnancies by using an electrical cardiometry monitor. Compared to C-section and vaginal delivery without anesthesia, vaginal delivery with epidural anesthesia shows the lowest cardiac index with the minimum changes in 30 minutes before and after delivery. As I mentioned, maternal cardiac output peaks immediately after delivery because of O transfusion. Epidural anesthesia increases the vascular capacity and may reduce preload. The study proved that vaginal delivery with epidural anesthesia could be the first preference for most cardiac patients. We also compared outcomes by the mothers of anesthesia for C-section. General anesthesia was performed in 47 C-sections for women with CHD, and neuroaxial anesthesia was in 214. General anesthesia was chosen in earlier times and for women with more severe cardiac conditions than neuroaxial anesthesia. Postpartum cardiovascular events, which occurred within 1 week after C-section, were found in 8% of neuroaxial and in 15% of general anesthesia group. After a statistical correction by severity of the disease, such as modified WHO class, general anesthesia is not a risk factor of postpartum events. Short summary, cardiovascular complication rate in pregnancies with CHD is about 1 to 10%, but it's up to 100% in modified WHO class 4 patients. In the contrary, general population is less than 1%. There are times when complications are more likely to occur. Preterm delivery rate in pregnancy with CHD is 10 to 20%. In general population, it's approximately 5%. Vaginal delivery with epidural anesthesia can reduce cardiac load. I'm showing the same graph. As you see, postpartum is the time to be followed carefully as well as antepartum. Here is a pregnant case with spontan circulation. Her pregnancy was uneventful and delivered at 37 weeks gestation. Her BNP levels remained within normal limit pre and during pregnancy. Her echocardiographic results did not change, and CTL returned pre-pregnancy value 1 month after delivery. 2 weeks later, she emergently visited in a hospital and complained shortness of breath, edema, and body weight gain 3 kilograms per 2 weeks. CTL became larger. The BNP level was significantly elevated around 300, echocardiogram showed increased AV valve dilatation. Can anyone tell what caused her heart failure? There was only one different condition between 1 month after delivery and 2 weeks later. Until 1 month postpartum checkup, she stayed at her parents' home. Because she was fine at the checkup, she moved to her home. Do you know how useless Japanese husband is for nursing baby and housekeeping? How about in Korea, Taiwan, and Singapore? And after this experience, I explained how important the family support after childbirth is at preconception counseling, especially to husband. Okay. We investigated breastfeeding status and late postpartum cardiac events in 153 women with CHD. Interestingly, more severe cases tended to use mainly formula. Thus, the formula group had a higher rate of late postpartum cardiac events. In multivariate analysis showed only medication use was a significant predictor for the events. The next, I'm showing effect of pregnancy on long-term outcomes. This is a case of repaired TOF with severe PL. Her CTL became larger during pregnancy and did not recover, or even become worse 1 year after delivery. Several studies have shown that pregnancy affects the right ventricle more than the left ventricle. This is a study to follow echo parameters in pregnancies with repaired TOF. Changes of left ventricle diameters are small and do not change before and after pregnancy. On the contrary, right ventricle diameters increase throughout pregnancy and also in postpartum. Here is a CMR study for women with repaired TOF. Women with repaired TOF who had completed pregnancy appeared to experience an accelerated rate of right ventricular remodeling compared to the much non-pregnant group. This tendency was obvious in those with severely dilated RV at baseline. Here's another important information about postpartum follow-up, a famous phrase. Pregnancy is a stress test in a woman's life. Women with heart disease, complicated with peripartum cardiac events, tend to have another event within 5 years after delivery. This applies not only cardiac complications, but also obstetrical complications in general population. Many studies suggest that infertility, HDP, GDM, preterm delivery, SGA, those factors predict future cardiovascular events. Therefore, women with CHD who have experienced peripartum complications should be more carefully followed up in postpartum and long term. My last topic is contraception. Oral contraceptives are widely used by women. However, as you know, combined hormonal contraceptives containing estrogen have thrombosis risk. It is not recommended to use in women with the first and the second generation mechanical valves, ischemic heart disease, pulmonary hypertension, severely reduced left ventricular contraction, and arthritis. Are there good contraceptive methods which are safe and highly effective for women with CHD? Yes, we usually recommended intrauterine contraceptive device called Mirena IUS. We have We have to be careful at its insertion about IE and vasovagal syncope. We reviewed 33 women with heart disease who used Mirena IUS. Many of them took warfarin and complained about very long and much volume than menstrual problems. Most of women declared their menstrual blood amount decreased after Mirena insertion. In the result, their mean hemoglobin levels were increased. Among women with increased hemoglobin levels tend to show decreasing BNP. IUS can be used safely among women with heart disease, and moreover, there is a possibility to improve their conditions via increasing hemoglobin levels. This is my last slide. Women with CHD still need close follow-up in postpartum. Pregnancy may affect long-term outcomes in some cases, such as cases with dilated right ventricle. Caution is needed in selecting contraceptives for women with CHD. Thank you very much.
Thank you, Dr. Kamiya. It's always, your lecture is always nice.
Thank you.
In the each, say, difficult cases, probably it's a very educational information for the audience.
Thank you.
Thank you very much. So we like to move to the next speaker, Joko Wan. I don't need a introduction, anything for Joko Wan. You are too famous.
Oh, really?
So welcome. No, I'm a visitor. You are in a Taipei major doctors. So do you okay for the start your lecture? For
yeah. Oh, yeah.
Adult congenital heart disease interventions.
Okay.
But your slides are not presentation.
Yeah, right.
Don't be rushed. It's okay for the I will wait your the slide comes. So the intervention is a very important.
Is it okay? You see my
not coming yet.
Not yet. Okay, I try.
So the adult simple lesions is probably a very good target for the catheter interventions. Also, probably he will talk about new developed for the say pulmonary valve in transcatheter pulmonary valve implantations.
Have you?
Okay.
So now your presentation slide comes to the screen.
So, Tage, do you see my slide?
Yeah, I see you. I see your slide.
Okay.
Why don't you click for that say slideshow?
Okay. So I would like to thank the organizing committee and Mei Huan Wu, who just rushed into my room and help me to show the slides. So I would like to talk about catheter intervention in ACSD. And the interventional procedure for ACSD, we may have ASD and PFO closure, most common, and VSD closure, PDA closure, ruptured sinus valve closure, and also for stenotic lesion, PS, AS valvuloplasty, and coarctation aorta stenting, and pulmonary valve replacement, and also CAS coronary artery fistula embolization. And before we do the intervention, we have to evaluate patient. How about the general condition, functional class, heart failure, arrhythmia, any pacemaker, comorbidities such as CAD, hypertension, metabolic syndrome. And this is our surgeon, and this is me. And we visited Vienna and Turf. And because of catheter intervention in my mind, is less traumatic to the patient. So I think for every congenital lesion defect, catheter closure will be the first choice. If we fail, then we need the surgeon backup to replace our role in the treatment. And so I will try to repair every lesion in via interventional procedure. And X-ray, echo, CT, 3D with 3D reconstruction is most common used tool, and also MRI to evaluate the valve, and also pulmonary valve regurgitation fraction. And also we can use 3D reconstruction to see the morphology of the pulmonary arteries. And catheter closure of that to right shunt lesion, ASD, VSPDA, rupture sinus basaba. And ASD in adult is usually remain undiagnosed until adulthood. And because of subtle symptom in childhood. And ASD is the most common CSD diagnosed in adults, and presenting with arrhythmia, heart failure. And we have seen a lot of cases presented with atrial flutter, arrhythmia, and atrial fibrillation, and also heart failure like this patient. So if patient associated with atrial arrhythmia, should we send them to the electrophysiology to evaluate first? And if it's possible, ablation, then catheter closure, I think this will be better. But however, patient with permanent atrial fibrillation, the pulmonary vein isolation was not so effective in patient with ASD. And catheter closure is another option if the atrial fibrillation is permanent. And we have to look at the pulmonary artery pressure. We have to do some hemodynamic study, and sometimes I do pulmonary artery wedge angio, and PVR, PVRI, and O2 saturation, balloon test occlusion is crucial before closing the defect. And this is a recommendation. PVR less than 3 with unit, then 1 is 1B. PVR 3 to 5 unit with QPQS more than 1.5 is class 2B, but we have to evaluate individual case. And if PVR more than 5 with unit, we started target therapy. If PVR less than 5 with unit with a QPQS more than 5, and fenestrating on the device can be used to close the defect. If PVR more than 5 units, despite target therapy or the saturation on exercise, this is contraindicated. This is a case with large ASD in an adult, and we usually use 3D images to help our procedure. And after that, we can close with a large device, so maybe 40. And sometimes patients have multi-fenestrated defect like this one, and these 3D images. And I put 2 occluders. That's another one. And so I use 2 devices. So for patient with pulmonary artery hypertension, and I think the TAGE has a lot of experience in treat and repair. but I usually like to partial repair and treat, use a fenestrating device. And this is a diagram that if PVR more than 8, maybe the catheter closure should not be performed. And we do some fenestration like this. Usually I like to make 2 fenestrations, and one larger one and one smaller one to keep that, to ensure that there's fenestration. And sometimes I stand the fenestration several months later, like this one. And how the PFO closure is not so many in Taiwan. Patient have, we usually, the neurologists refer the patient to us because of cystogenic stroke. And we have to look at the heart where there is right to left shunt, use echo contrast or bubble test, and device closure if there is history of stroke and the positive right to left shunt. And VSD in adults, because VSD is most common defect in CSD, but still we can close the defect, the VSD in Taiwan. Patient may have heart failure, pulmonary hypertension, aortic valve prolapse, AR, and infected endocarditis. In Taiwan, we are allowed to close the VSD if there is significant left to right shunt without severe pulmonary hypertension or LV dilatation or progression of aortic valve prolapse, AR, or history of infected endocarditis. And we now have 2 types of device that was covered by our insurance. One is SELA membranous VSD occluder. Another is we so-called MFO. And muscular occluder are also available for closed muscular type VSD. But the muscular type VSD is not so many in oriental patients. This is a large VSD. You can see the shunt and QPK is 2.1 and with mild pulmonary hypertension. And you can see the defect extend a little more to the aortic valve. And we use a SELA device to close the defect. And you can see that, and 3D also quite helpful. You can see the defect here. And after that, device is here. And this is 75-year-old male with residual VSD after operation. And you can see the defect 0.9 and QPQ is 1.6 and with my AR. So we close it with 12 millimeter LiveTech symmetric device. And this is another one with 7.5 millimeter defect. And we close with MFO. You can see that we open MFO in the aorta, then pull a little bit back to LV. Then finally, it's in good position. And the angiolitis, some small residual shunt. Okay. And the postally TTE. Okay. PDE in adults, also there are some cases, majority have symptoms, and you can see the calcified ductus and usually large, AD01 is more common device used in closed PDA. This is patient with a large, sorry. Oh, didn't move at all. Right, sorry. And we can, this is another one with a large defect. And we do the wedge angle, and there's somehow had the pulmonary hypertension. Sorry, there's a problem.
No, we can understand.
Okay, but I think it's okay that we have some cases with ruptured sinus basaba. I think this is more common in Oriental people, and this ruptured sinus basaba into right atrium. Oh, did I move? So we use AD01 to close the defect. And you can see here. And coarctation of the aorta in adults, there's also not so many comparing to the Western population. The indication is pressure gradient more than 20 millimeter and narrowing on senior MRI. And balloon dilatation is not so effective in adults. And also there's maybe some dissection. So stent will be more effective and also safer, especially cover stent will be better if the narrow is severe. And long segment stenosis or isthmus hyperplasia should be operated. Sorry, this is a case of coarctation stenting. And finally, pulmonary valve replacement in patient, especially tetraphyllite after operation, moderate to severe PR may appear decades later, and pulmonary valve replacement is required in around 30% patients. And because of transannular patch of RVOT was usually placed in our country, and also I think also in Japan. And PR severity increase with age. And so PR is not a benign lesion. And this is the indication for the pulmonary valve replacement. And right ventricle and diastolic volume index by MRI more than 150 per square meter, or RV and systolic volume more than 75 to 80 milliliter per square meter, and present significant pulmonary regurgitation for PR index more than 30%, RV dysfunction, ejection fraction less than 40. So maybe if there are 3 criteria, the device will be covered by our insurance. And currently we have Pasta valve and Medi valve in Taiwan, and venous P valve also underwent the clinical trial. We have 15 case experience, and the Melody valve can implant in patient with RVOT less than 22 millimeter. And Pasta valve can be implanted in patient with a diameter less than 30. So the maximum size of Pasta valve is 32. And now we use a lot of Pasta valve now because you know, either the Swiss requirement is low, maybe 18 or 20 French sheets is enough, and very easy. Not really easy. It's very convenient to deploy the valve. And we have to look at the types, the RVOT morphology, and this pyramidal type is very difficult to treat, and especially very challenging And type 2, very straight type is easier and safer. And type 3, maybe in only some selected patients. Type 4 is diabetes, is maybe many patients have type 4, and type 5, most patients can receive this kind of self-expandable valve. Sorry. And this is a pulmonary regurgitation angio. You can see the calcified RVOT because of the patch. And we have to do sizing to measure the narrowest diameter is 27. And we have to test coronary artery compression. And we deploy the valve in the distal main pulmonary artery, then opening gradually, and finally the valve was deployed. This is another case. And some patient has the parababatic after valve replacement. This is case with parababatic, and there's two major leaks. So we use the device from transapical approach because this patient has tried surgery before. And we implant the first device, then the second device. So this is my take-home messages. Simple left to right shunt lesion without pulmonary hypertension can be safely treated with transcatheter technique in most patients, except outlet type VSD and Kremen type ASD. In patients with associated pulmonary hypertension, careful evaluation is crucial before catheter closure. And the transcatheter pulmonary valve replacement is an alternative to surgery in many catastrophic valve repair patients. And we are very lucky that this valve is now covered by our health insurance. So we can do a lot of patients. And be careful, we have to make good friends with surgeon. We always have surgeons stand by, and team approach is required. So thank you very much for your attention. Thank you.
Joko, thank you very much. And the situation for the day, one is a very big number is atrial septal defect. And
yeah.
In adult case, how do you say how patient transfer to your clinic from the adult cardiologist or the say in physicians and the regular physicians to your hospital?
Oh, that's a very good question. Because of the half of them referred by our adult cardiologist, and half of them walk in. They can see me and register at my clinic, and then
I see.
And also our colleague like Dr. Lu and Professor Wu also refer the adult patient to me. So I think we work as a team. So we share all the cases.
And some of the patients may have some, say, left ventricle dysfunction, diastolic dysfunction. You may worry about closure for the ASD. So how do you indicate for that, especially for such kind of, say, diastolic dysfunction of the left ventricle?
That's a very difficult question to answer. Usually we, if there is diastolic dysfunction, we can have some tests like a dopamine test, infusion to see where the cardiac function will be increased, or sometimes we use Lasix And if there, sometimes we see the hemodynamic, if there diastolic dysfunction, then LA pressure or LV and diastolic pressure will be elevated. And balloon testing before closure, and usually in patients with significant diastolic dysfunction, I will fenestrate the device. Then it will be safer than make a big fenestration instead of like a small fenestration.
I see.
How about you, Tej?
Yeah, we do the, say, initially we do the, say, the additional heart failure management, because most of the adult patient is not completely heart failure management, just say they have less symptoms. So we do the heart failure management at first, then think about the next step.
Okay.
So that is a very important. Also, the arrhythmia management is also very important.
Okay.
Yes.
Thank you.
Yeah, thank you very much. Thank you, Joko.
Okay.
So we like to move for the final speaker, Julie Tan. Julie, how are you?
I'm good, thank you. Good to see all of you on the web.
Yeah, thank you for coming for the, say, in this ACHD webinar. The topics is, say, very important for the transition for the pediatrics to adult, or the, say, pediatric hospital to the adult hospital. Please start your lecture.
Thank you very much. So thank you, Teji, and thanks to the committee for the invitation. So my topic today is very different from everybody else. It's on transition and transfer of the patients to the adult congenital heart clinic. So I'm going to basically divide this talk into an introduction on what is the transition clinic and why is there a need, and then on setting up this transition clinic and the challenges that need to be overcome. And also, lastly, I will share our experience in Singapore and on our transition clinic, which we call the Young Adult Congenital Heart Clinic. So what is transition clinic and why is there a need for transition? So essentially, the American Academy of Pediatrics states goal of transition in healthcare is really, especially in healthcare of young adults with special healthcare needs, is really to maximize the lifelong functioning and potential. And this is through provision of high quality and then developmentally appropriate healthcare services that continue uninterrupted as the individual moves from adolescence to adulthood. So you can imagine an adolescent is really at a crossroad, right? They have so many things to think about. What's the changes ahead? You know, they're a little bit confused. They're unsure. You know, they are in a way a semi-identity crisis. They are looking very much to a new life, but they are also afraid of giving up their old life. So we must bear in mind as the adolescents develop, there are several developmental tasks that they usually have to overcome. So for example, adolescents have to, you know, consider socializing with peers, how to socialize correctly. They have to accept that their body is changing and accept the physical changes in their body. They have to start establishing social roles, what's gender identity. They are trying to be more independent. Again, the relationship with their family maybe changes. And then at the same time, they are maybe establishing intimate relationship with the opposite gender. They think about the future job, what's the career. Then at the same time, their values, their ethics, you know, how they should behave and what is socially responsible. So in essence, transition is really a passage from one life phase. So it's from one life phase of adolescence to another life phase of adulthood. When they do this adjustment passage, there is at times a disconnectedness from the normal way of doing things. So when we said we provide transitional care, it's essentially a provision of interventions that caters to the medical, the psychosocial, the educational needs of the adolescents. What you want is you want them to move towards becoming independent and to be able to take charge of their lives. So the transition program is then a set of transitional care intervention that will help you to do this, right? And then you have a plan which says, okay, this is what you're going to do, and these are your goals and how you're going to achieve that. So transition is an essential passage of life, and hopefully for a better outcome. So if we look at the 2021 ESC consensus statement on transition to adulthood and transfer to adult care, you can see that the transition age really starts somewhere between 14 and can go on to 20, right? So you should really start a couple of years before the transfer of care. And there should be a transition plan which involves some counseling and education. You look at the needs. At some stage, you may want to introduce the ACHD team and then provide some kind of guidance to the parents. So you can see somewhere between 14 and then roughly about 20, you should really transfer the care. And this is important because we know now that 90% of children are born with adult congenital heart disease are surviving to adulthood, but 26.1% experience some kind of interruption in this care. So why is there a need for transition in congenital heart disease? So we know that as patients get older, just as they change school from primary to secondary school, the healthcare needs of patients also need to change. In childhood, the emphasis is on correct diagnosis, on growth, on development, but in adulthood, the emphasis is different, right? Most of the lesions are already corrected. So you look at the residue and the sequelae of the surgery, you look at the physical and emotional effects of living with uncorrected defects or palliated defects, you look at the effects on work, on exercise, and subsequently childbirth, and then you kind of anticipate what are the long-term complications. And not only that, as the patient gets older, there's also development of acquired cardiac and non-cardiac disease and the impact of the underlying congenital heart disease. American College of Cardiology says that transition process should really start at early adolescence. And in the ESC consensus statement, they say probably should start somewhere pre-transition from the age of 14. Optimal age of transfer is 18 to 19, but patient preference is actually earlier. So in real life, I think the transition process should be depending on the patient's developmental and medical condition and should be individualized. Not only that, you should look at what is the society, development and what is the best age to transition in your society and in your country. So in Singapore, we run the adult program, and our feeder, which is basically the KK Children's Hospital, we have a collaboration with this transition program. And most of all patients, in fact, are seen from the age of 16 onwards. But conversations about transition really starts from the age of 14 to 15 by the pediatric cardiologists to mentally prepare these patients for successful uninterrupted transition. This is important as most of these patients has been followed up since birth and early childhood. So there's always a strong attachment and loyalty to their pediatric cardiologists and the pediatric institution. So in the transition process, we need to allow time for the patients to say goodbye to their pediatric cardiologist, and this can be a handshake, a nod, a hug, or whatever, but they have to have proper avenue for them to say goodbye and then move on. So let's carry on with the setting up of the transition clinic and what are the challenges to overcome. So I think essential knowledge for a successful transition clinic is, first of all, we must understand the patient. We must see the diagnosis and prognosis from the patient's perspective. Try to see the problem from the patient's side, right? And we should not have judgment or bias, ideas about the patient's own subjective experience, because we are not them. So we have to evaluate what is the emotional behavior and maybe the social adjustment that they need to overcome. At the same time, we have to encourage them to take more active role. We have to look at what are their behavioral patterns and modifications. We should maybe advise them they should not smoke, talk a little bit about drugs, alcohol, and then to also understand what are their expectations on their future health and their life expectancy. So we also have to understand at the same time the parents and the family, what's the impact of the congenital heart problems on the parents, on the siblings. We have to look at the parent-child relationship and dynamics. What is the anxiety on the parent side? Are they comfortable for the patient to go into adult care model? And also, what is the role of the congenital heart disease in limiting the child's activity or the adolescent's activity, and then maybe some kind of advice on that. So at the bottom of all this slide is a busy slide, but all I wanted you to understand from this slide is this word, patient empowerment. So we want to educate the patient, give them knowledge to empower them so they can make good judgment. That's the gist of it, right? And then we must be cognizant that there are developmental tasks and issues that adolescents have to face. That is a little bit different from the normal adult patients. So the transition clinic usually has a transition curriculum. And these are some of the topics that we cover. Of course, if you're setting up this program, you should decide on what are the topics that should be covered by your clinic. So essentially, we look at the medical problems first. What are the cardiac, the post-surgical and non-cardiac medical problems? We look a little bit at the background, whether there are behavioral issues. We look at if the patients are on medication and whether this going forward, these are the medication that we want them to continue. We look at dental care and whether the need for antibiotic prophylaxis. Exercise and sports are important because most adolescents are active. And in Singapore, the male patients have to go for enlistment at the age of 18. So we have to provide the report to the SAF, the Army, to say, you know, so they have some idea if the patient can enlist and what is their past class. We have to see whether the patient is going overseas for studies. We have to see their traveling, whether they need oxygen. And then we have to talk about what are their future career plans, employment, what is suitable for them. At the same time, we have to advise them on diet, on alcohol, on vaccinations, you know, on cholesterol, and these are the issues, genetic, and on, if they are female, on contraception, and on pregnancy. So it's very important, we must select the medical reports, what are the notes we want to take from the pediatric to the adult setting. And if you have electronic transfer, how are you going to transfer those? And if you don't, then at least some paper transfer, but you're not going to take everything. You're only going to take the important ones, right? So in the clinic, we look at, again, all these issues that we have discussed. So what are the residual problems? Is there a need for further surgery? We need to engage this patient and start the discussion. And if they need further surgery, is this best done in the pediatric setting, or should we transfer them to the adult setting and get it done there, right? And we should tell them what are the signs and symptoms to look out for, and make sure the patient really understand their anatomy, their physiology, and what kind of surgery they have done. There are also non-cardiac surgical issues we have to consider in some patients. Some of them may have orthopedic problems, make sure that their dental is good. We may need to refer them to see the dentist, and et cetera, et cetera. Exercise is very, very important. And I think many children are encouraged not to exercise, but this is slowly changing. And we need to educate the children and the parents why exercise is important. And then discussion should be focused on really what they cannot do, because nobody likes to be told what they cannot do, but we should emphasize on what they can do and what activity we need to encourage. And there are many guidelines out there that can help us to tell us, for example, this 2020 ESC guidelines on sports and what are the sports and activity that the patient can participate in. What about education and career? So Veltman actually reported that only 22% of patients actually could identify their diagnosis correctly. And 36% have a wrong understanding and wrong idea of their illness. So we need education, right? At the same time, we must also be aware that because of the early surgery, sometimes in neonates or early infancy, the patient may have adverse neurodevelopmental outcomes. They may sometimes have hyperactivity, behavioral issues, and etc. So we may need to give them career counseling as well, looking at their lesion, and then, you know, encourage them to tell us what they want to do and maybe guide them along the way. And also there's a high rate of unemployment in UK, we can see. And a lot of the time we also need to educate future employers why actually this patient should be given a job and why there shouldn't be so much fear of congenital patients, even in complex congenital patients, of getting the jobs that they want. And they will be actually useful to society and to society as a whole, and they should be able to contribute effectively. So patients with developmental delay and disability, this is another big group. So adult cardiologists are usually not so good. So we should be familiar what are the syndromes, what does it imply, and how we should follow them up. So let me take you through to our young adult congenital clinic. But before that, I would like to highlight this article that is published last year. And you can see that only 42% of 96 ACHE centers in Europe has a formal transition program, although 88.5% has a structured transfer program. So if you look at across many countries in Europe, as you can see, transition only 40 have, and 56 of these centers do not have a transition program. And 38 have a transfer program, and 9 has no transfer program. And you can see across an individual country, there's really a lot of variation. And you can see also on the other table, transition and transfer the age, right? Some starts at 14 and then goes on to age 25. Some still continue in center 23 to transfer patient up to age 35. So there is really a lot of variation there. And I think despite some improvement, there are a lot of the programs lack an age and development based kind of approach. And if you look at quality indicators for transfer, having a structured transfer is one quality, transferring all patients, having some kind of overlap, a flexible transfer, and the youth getting some detailed medical record, and ACHD team receiving patients' complete medical history. So, and then the indication for transition, having a good program, having a transition specialist, education, some written protocol, flexible transition period. So these are all the transfer factors, good factors, and quality indicators. But if you look at this chart here, across all the centers in Europe, you can see, if you look at only 4 centers have a maximum of 6 transition criteria. And a lot of centers have 6 transfer criteria, but no transition criteria. So you can see there's a whole lot of mix, and very, very few centers actually achieve maximum transition or transfer quality indicators. So there are 4 models of transition care. For us in Singapore, we have the joint clinic model where the adult cardiologist visits the clinic at the pediatric center and then have a clinic there and then transfer the care. There's also other models such as introductory model where the pediatric cardiologist visits the ACHE clinic and then introduce the team. There is also the pediatrician in adult care model. There's also a transition coordinator model. This is usually run by advanced practice nurse. So you have to decide in your center which is the model that you're going to go for. Now remember, transition is not transfer. So just having the patients transfer to adult center, that is not a transition program. So transition program need to have a pre-transition, start of transition, transfer, and then end of transition. So in our program, our aim is to prepare young adults for successful uninterrupted transition. We want to optimize potential and productivity. We want to improve quality of life and life expectancy. And we do this through education, through communication, through patient empowerment. And our emphasis is always more on the patient and less on the parents. So I'm going to go through the 3 pre-transition phase. Again, this starts in Singapore about age 13 to 14. This is started by the pediatric cardiologist and involves the family. And sometimes this role can also be fulfilled by advanced practice nurse. Then the patient goes into the transition phase where they actually see us in transition clinic, and we try to go through the transition checklist, what we must go through. And we need to, again, educate them, to teach them to recognize the concerning symptoms and signs. to make sure that they understand what the therapy in the future involve and also how to navigate the adult healthcare setting. Then we transfer the patients, and usually we transfer at the age of 16, but sometimes if they are not mentally prepared, we can then defer up to the age of 20, and I can see them in the transition clinic a couple of times before transferring. And why at the age of 16 or 17 or 18? This is because of educational milestone. Most patients like to finish maybe their A-levels or IB, and then somehow they think they are more like adult and they're ready for transfer to adult care. So adult care is a little bit different. It requires more personal autonomy and responsibility, and we have to see the patient is ready for this. And we try not to transfer during a medical crisis. Like, for example, if they are pregnant or they're mentally ill, because it imposed really a tremendous psychological burden and a sense of abandonment. So remember that coordinated transfer is crucial. You need to make sure you have kind of health summary or report, medication list, look at what are the issues, and then address any questions by the patients and their family before transfer. So for us, we do it once a month on the last Friday of the month. Over the years, we have transferred about 100 to 150 patients every year. The adult cardiologists like myself or my team members, there are 4 of us, but usually 2 of us will go and we will run the clinic with the pediatric cardiologists. And this is what the clinic looks like. Usually I'm quite happy going there because it's really different from the adult clinics. It's very bright. There's lots of interesting murals, insects and flowers, and it's really quite different from the adult clinic. And we make sure that we are friendly and to everybody there, including the reception counters, because they help us in the clinic. I usually bring a stethoscope and a kind of field guide. So with a nice diagram, so I can do the education. And then I explain the diagnosis and make sure that they are comfortable. And if they are so, then we tell them when are they going to transfer. And then we make sure we get all the important notes. And if there's electronic transfer, then that will be the best. And then usually about 5 o'clock we'll finish. And this is myself with the pediatric cardiologist and a whole list of patients. We will take them over, and usually out of 25 patients, about 20 to 22 will show up, and about 80 to 90% will be ready for transfer. Some may have residual problems. We need to rediscuss, and then we can decide if the investigation, such as CT or MRI, is best done in the pediatric center or the adult center. And I think some patients need more time. So in conclusion, many children born with congenital heart disease are surviving to adulthood and need to be transferred from pediatric to adult care. And transfer is not transition. You need a structured transition program with clear aim and a curriculum to help you in this process. Setting up a transition clinic requires close collaboration between pediatric and adult healthcare providers. So there must be a common agreement as to the timing, the preparation, the program, and then it has to be a coordinated process. And I think nurses are essential as transition coordinators, and they can play an important role too as educators. I think a good transition program will help to ensure that young patients with chronic disease, such as congenital heart disease, are well looked after for the rest of their lives. Thank you very much.
Thank you, Jolene. I think to say this kind of the program is very important for the continuous medical management for the young patient to the adult clinic. And on the other side, it's already many patients already grown up, and some of them may drop out of the follow-up. So now we are trying to something like a promotion about bring them back to the clinic for that is of course that must be adult clinic. That kind of promotion we are thinking in Japan. How do you think about the patient already drop out for the follow-up?
Yeah, okay. Thank you for the question. And this is very difficult. So normally when patients get transferred, so I have a whole list of patients' names. So they are given an appointment, and if they don't come, I will get my nurse to call them once. And then if still don't come, we can call them 2 times. And then if you if you do that, I mean, you cannot force them to come, you know, then if they really don't, and if they have complex congenital, then one of the physicians will try to call them. But if they still don't want to come, I think you've done your best. You know, you have a program to try to ensure that. But I think if you have a pre-transition and you educate the patient and their family right at the beginning, they are more likely not to drop out of the program because they understand the importance of why they need to come to you, because you would tell them that this is not the end of it. These are the various problems that can happen in adulthood, and that's why you need to come, because we need to ensure that these problems are dealt with before they become severe. So having a pre-transition program, a kind of really repeated education, maybe from the age of 14, 15, 16, you know, until it's in their head, and then they will want to come. But the later, the ones that didn't come, that one is very difficult. So I think only say start from here and move forward.
Yeah, mostly, for example, like I say, patient had a tetralogy fellow, they already age 40 years old. That kind of, if the condition is stable, that patient is lost of the follow-up. So that is our big issue for the how do they bring back to the hospital. That is our current issue for the adult congenital heart disease, already lost up adult patients.
So the other thing you can do is you can educate your adult cardiologist, because at some stage, let's say a tetralogy at 40 years old, they would have at some stage come with arrhythmias. Then they may present to the adult cardiologist. Or you know the adult, or they have coronary artery disease. I see that in a couple of my congenital patients now, like tetralogy, because they smoke and they are, you know, they have diabetes and they have coronary artery disease. Then they will pop up in the adult cardiologist. And then you must tell your adult colleagues, you know, please, if you have any congenital patients, besides sorting out the adult problems, please also send them back to us. So I think that kind of dialogue can also help you to get some of the patients back. Yeah.
Okay, Julie, thank you. So how about the other lecturers today? Don't they want to some more comment or some of the talk, additional talk at this point? Dr. Kamiya, how about say your announcing about how do we talk about say young patient about their the pregnancy or delivery in your say before pregnancy counseling?
Yeah, right now at the NCVC where I'm working, many of ACHD women are introduced to my preconception counseling outpatient clinic, but most of them are over aged 20 years old. So I'm not going to, you know, do the preconception counseling for teenagers yet. And I think for teenagers, maybe before the transition, I think it's better for pediatric cardiologist or specialized nurse to give some information about pregnancy risk to the CHD patient.
Okay.
I think.
Okay. Thank you very much. So Julie, do you have how about your clinic is say, of course, they say anatomy is a very important say education for the patients. For the women's patient, pregnancy or delivery, that is a big issue. How do you think about that?
Yeah, thank you. It's a pretty kind of sensitive topic. Usually, if they are teenager, I see them 16 or 17 years old. If they come with their parents, then I mentioned a little bit about pregnancy in the future. You know, what are their risks? That kind of thing. And then I will kind of look at the parent and the relationship. Now, because if you tell them about contraception at this age, right, some of the parents will, you know, the eyes will open and look at me because they think that the children is not ready. But saying that, sometimes we have had a few teenage pregnancy because this topic was not discussed at all. Yeah. So sometimes I would say, you know, if they come on their own, it's easier. If they come on their own and you know, I ask them, okay, you're in college or whatever. Sometimes I ask them, do you have boyfriends? And do you want to ask me anything? And then, you know, you sometimes cannot do this on the first visit because they are not comfortable with you. So you may have to do it with a few more visits when they've seen you a couple of times and they're ready to open up. And then it would be good if you have some kind of leaflet on contraception because you can give it to them and say, you know, maybe there's some information on contraception and give it to you. You can read about it. If there's any question, maybe you can, you know, talk to my nurse and things like that. So give them opportunities to ask again. Yeah. I think just be very careful when they have both parents and the parents are not comfortable, because the next thing you want is the parents telling the pediatric cardiologist, I don't like this adult cardiologist. I think my children's not ready to transfer, you know, I think they need a few more years. So we've had this. So I think we have to be very, very mindful.
Yeah, that is important for say. Also, doctors involved that this adult congenital heart disease in adult cardiology has to be trained about say that kind of say the importance, and usually first few outpatient clinic take a very have a very important period for the good communication each other. So that is that process, say recognition is very important. That is especially for the adult cardiologists. The next after transition. Thank you, Julie.
Thank you.
So I like to using this short time, I like to introduce for this Friday's topics. Our Japanese Society of the Adult Congenital Heart Disease that we are promoting about the Asian Pacific Society for the ACHD night. And this Friday, we have topics about the pulmonary artery hypertension of ACHD in Asia. So in Japan time, it's at 9 p.m. So Julie, you are, what time? 5 p.m. in the Singapore time?
I think
6.
6, I think. 6 o'clock. Yeah, 6 o'clock.
So we have 5 very important speakers this Friday. So please join our webinar. And this is the only 1 hour program, but probably it's a very exciting topics. So thank you very much for everyone. If you have no any more the comment, I like to close this program. Thank you very much.